So this is Emergency Medicine and Radiology Tips for the Print Conference 2015. This can be either used for revision after the conference or you can watch it before. So the learning objectives for this talk, which is going to be over the course of an hour with a quiz, is going to be the following things. So we're going to be able to describe a fracture, how to call a colleague about the problem that you've got in front of you, how to use your clinical expertise to identify where particular tubes may be, such as endotracheal tubes, nasogastric tubes, and chest tubes. Quick introduction to C-spine x-rays as well as chest x-rays in detail. So you're going to be expected to read chest x-rays, find lines on a film, and describe a fracture over the phone. These are pretty standard things you're going to be expected to do as an intern. But you're not going to be expected to do much more in the way of CT reading or C-spine imaging. If you're really keen and you're systematic, you're going to learn loads about x-ray interpretation during the year. So, how do you describe a fracture and how do you call for help? Can you confidently describe a fracture? So, our suggestion is to use ISBAR and a systematic way of going through fractures as follows. Here's a good example of a fracture dislocation of the hip. It's a really nasty comminuted fracture. A spiral fracture, in fact, of the shaft of the femur. What you'll notice, however, is that the femoral head is also displaced. There's an acetabular fracture, and in fact there's also this medial pubic ramus fracture, which is quite concerning. This patient may well be hemodynamically unstable, the fracture may well be open, and the patient will have neurovascular problems as a result of it. And this needs to be put back into place on a fairly urgent basis. So here's another example of a nasty fracture in a 10-year-old. I'll just give you a second to look at this and decide how you're going to describe it over the phone. So let's just say that you're not quite sure what to do. Where can you get help? Well, there's lots of places you can get help. ED staff, surgical medical staff, even your radiographers and radiologists will really appreciate it if you ask them for help. There's a whole bunch of books that you can use. We'd recommend Emergency Medicine Radiology, a survival guide by Nigel Ruby, as well as various apps such as the Radiopedia app. So in summary, you get a call for help using ISBAR. Keep it short and concise. Don't forget about neurovascular deficits, open and closed fractures, and the hemodynamic stability of the patient when you call. How are you going to find your line? Well, we often describe this as apparatus on the chest x-ray, central lines, endotracheal tubes, and other devices. So it's useful to think about the anatomy of what you're looking at on the x-ray, such as the venous and bronchial anatomy. PICC lines can be positioned from the right or left arm and come in through the subclavian vein into the proximal SVC. Sometimes they can be malpositioned by going up into the internal jugular. Other central lines may look like this. This is an internal jugular catheter sitting in the proximal superior vena cava. Nasogastric tubes need to be below the lower esophageal sphincter, around 10 centimeters. And it's important to look for the tip. The tip needs to be below the diaphragm by a substantial margin to avoid aspiration. Here's some examples of nasogastric tubes gone wrong. For example, kinking of the tube in the mouth, reversal of the tube back up the esophagus, or even aspiration of contents out of a nasogastric tube placed in the bronchial tree. Here's another example of a nasogastric tube in the bronchial tree. What you're looking for it to be in the correct position is slightly to the left of the midline, coming down here and below the diaphragm, and this is clearly gone to the carina, down the left main bronchus and back around into the right main bronchus. So intubated patients may be quite difficult, and you can't always see the tip of the endotracheal tube, but it should be just below the clavicles and 4 centimeters above the carina. Here's an example. The endotracheal tube should be near the red arrows between the clavicles, and as you can see, it's a few centimeters above this triangle here, which represents the carina. Here's an example of a endotracheal tube and a right main bronchus intubation. The right lung is up and the left lung is down, so you need to pull this tube back. Chest tubes. Chest tubes are commonly placed in the ED and this patient has had a decompression of a tension pneumothorax. This chest tube looks in a good position at the line of the nipple and the mid-axillary line. The patient may have had something like this, a large pneumothorax, and after the chest tube is placed, you need to check that the tube goes through. It doesn't lie in the soft tissues, it goes all the way into the pleural space and sits nicely in that space there. Can't go wrong. This one's sitting in the left ventricle. You need to leave that one in. This one's an empyema with multiple tubes, some of which are kinked. Also a central line coming in and an endotracheal tube. Here is a gunshot wound. There's a bullet here. There's various monitoring, a recent thoracotomy, and a bunch of chest tubes in the chest as well as a splenic drain. Patient's intubated and has a central line. So in summary, lots to take in here, but you really need to look for the various apparatus on your chest x-ray. And be really careful when looking at a nasogastric tube not to let the patient get feeding into their lungs. So quickly going through the C-spine x-ray, think of yourself managing a patient who's been in a car crash. Think of how common C-spine injuries are. Well, they're not that common, but in major trauma patients, about 4 in 100 are going to have a significant C-spine injury. The signs of an injury to the neck are going to be things like neurological findings, pain in the neck, and obviously the mechanism that you have. And there's pros and cons to putting the patient in immobilization. If you stick a patient on a spinal board, they can get pressure sores, whereas if you don't, they can have significant sequelae to missed injuries. So the Nexus study in America looked at 34,000 patients or more. It didn't miss many significant C-spine injuries, but it basically said if you didn't have any of these 5 things, you were unlikely to have a C-spine injury. Distracting injuries are confusing, but what is a distracting injury? Well, it was defined as long bone fractures, visceral injuries, lacerations, burns. It can really be anything that produces any functional impairment or upset to the patient. So other studies more recently have suggested that chest injuries are the most important distracting injury you can have, and many patients can be missed when it comes to chest injuries. They may have no neck pain, they may have a C-spine injury. So moving on is the Canadian C-spine rule. This is a useful rule to use when you're working in the ED. It's a good way of clearing C-spines in low-risk patients. It basically says that if you've got a high-risk patient, you need to do radiography. If you've got a low-risk patient, you can rotate the neck. And regardless of whether they have pain or not, you can generally clear their neck. Here's an example of a C-spine x-ray. You need to identify your anatomy. C1, C2, C3, C5, C4, C6. And you want to see C7 and T1. You need to see the top of T1 for an adequate film. On a lateral C-spine x-ray, you want to look for 4 lines. So it's the anterior line here, posterior line here, spinal laminin line here, and posterior line here. So this is what it should look like. It should be nice and lined up. Shouldn't really be any step there. Here's an example of a significant step between 1 and 2, 2 and 3. And in addition to that, count 1, 2, 3, 4, 5, 6, 7. You can see T1. So this is an adequate film, but what you can see is a lot of soft tissue swelling here and a big step. So I'd be worried this patient's got a significant injury here. So I'm going to move on to chest x-rays. I'm going to zoom through some of these slides. The big question is to have a systematic approach. I should use a checklist. Checklists are pretty popular. The useful thing about checklists is that they stop you missing big things. I suggest checklists from Michael Caslin as the Dr. ABCDE approach. So look at the demographics, the quality of the film, the apparatus and the airway, the breathing, which includes mediastinum, hyaline, lungs, and the various diaphragmatic angles, circulation, a good close look at the diaphragm to the sensor there underneath the heart, and then everything else. Step back and consider the overall appearance if you can. This is where your clinical gestalt about the X-ray comes in combination with looking at the patient themselves. So is the film adequate? You need to work out whether it's rotated. Is it an AP or a PA film? An AP film may look abnormal in terms of the size of the heart. Is there much angulation or much problem with the penetration? You should see all the vertebral bodies as they go through the heart. Generally speaking, we do films on inspiration, but you may require an expiratory film for a pneumothorax. You can tell this is adequate because you should be able to see 6 anterior ribs. Generally don't find lateral films that useful, but if you're going to use one, it's usually for defining masses, looking closely at the level of the various opacifications you might have. You can define the anatomy of the various lobes more clearly in the lateral film. It's pretty boring, but you need to know about the various lung zones, the silhouettes, densities, as well as the terminology of opacification and lucency. The various lung zones are divided into 3. The upper 2 ribs represent zone 1, zone 2, and middle zone would be down to about the 4th or 5th rib, and then the rest of the lung field is reflected by the lower zone. The silhouette tends to reflect to the border of 2 densities, in other words, the heart with the lungs, and this can be changed in various. You may lose the silhouette or you may gain the silhouette depending on the problem. So for example, you've got pneumonia, you may lose the cardiac silhouette. There's various densities that are shown here. You've got air, fat, bone, soft tissue, but obviously metal is going to be even brighter than the bone. There's the various degrees of density shown here. So you've decided that the film quality is pretty good. What do? You move on to looking at the apparatus, describing the lines as well as the position of the trachea. So in this case, you can see the trachea is a bit shifted. There's a big opacification here, and everything's moved this way. There's a few lines to pick out here. You've got zipper clips, got some ECG dots. I'm not quite sure what this is here, but there's a foreign body of some sort, possibly the gastric tube coming down. It's hard to say whether it's gone back up into the chest though. And then the endotracheal tube seems to be pointing down here. So it's quite possibly a right main bronchus intubation, but it's also possible something's going on here pathologically. Another example, an intubated patient with various lines. There's a gastric tube coming down here, a Swan-Ganz catheter in the pulmonary artery, as well as a central line coming down here. So for breathing, we want to look at the mediastinum. Sometimes it can be a projection problem or a master that might make it big, but you've got to worry about aortic dissection. You also got to look for a pneumomediastinum. Here's an example of that. And another one where you can see these lucencies on the edge of the heart, which look quite abnormal. You need to look at the hilum as well. We're going back to the last film. You've got the pneumomediastinum here and here, but you've also got the hilum here. So the hilum is generally made up of pulmonary vessels, bronchial lymph nodes, and it can vary in position, shape, and density. Here's an example of when its density and position is not quite right. There's bulky lymphadenopathy bilaterally, and this is an example of sarcoidosis. You've got to describe the lung zones in detail. Look at any white stuff. Specifically describe the white stuff as consolidation, reticular, shadowing, or nodular. And always look carefully for a pneumothorax. Here's an example of a pneumothorax here. Also, there's a bit of a collection, possibly pleural effusion of some sort down here. Whether this is a hemopneumothorax or whether there's another cause of this effusion, who knows? You've definitely lost the heart border on both sides as well. So the question is this just due to a collapse of the lung or is something else going on? In terms of the circulation in the heart, you've got to look at the contours of the heart, the borders, the position of the heart, which may shift just like the mediastinum and the trachea. And interestingly, the fat pads, which are the medial findings of a loss of the diaphragm centrally, can be normal. You can lose that nice distinct shape here, and that can be due to a fat pad. Here's an example of the anatomy again, just showing you all the different issues you may have, but the heart border should be nice and distinct. Patients with a left ventricular failure have various changes. listed here. Here's an example. There's a large heart, there's fluffy shadowing, upper lobe diversion, and not so much a bat swing appearance, but quite an abnormal appearance of the hollow here. There's even some small pleural effusions there. In aortic dissection, you often have a wide mediastinum, but you may actually have a normal chest X-ray. Here's an example of an aortic dissection with a large hemothorax and possible pericardial effusion. Patients may have an unfolded aorta, which is common in elderly patients. It can be normal for them. Here's an unfolded aorta. There's other stuff to look for. Look at the diaphragm. Look for everything else. Don't miss any problems with the bones and soft tissues. So in summary, you need a systematic approach, and we suggest the DRABCDE approach to chest X-rays. I'm going to do some examples now. So here's a quiz. What I want to do is get a bit of paper and write down the various things that we see. Here's question 1. The 23-year-old person has come in who's short of breath. I'd like to describe and interpret his X-ray and outline the treatment options. Here's the answer. So basically it shows a pneumothorax, a needle thoracostomy, and no evidence of radiological tension. Here's case 2. We've got a patient who's been in a major car crash. You need to look at the X-ray, describe it as best you can, and then outline your management options for the patient. So here's the X-ray. So there's a wider mediastinum, there's a clavicle fracture, there's rib fractures, and a right pneumothorax. We'll go back. There's a wide mediastinum, there's a clavicle fracture. This side looks more white than this side, which suggests a hemothorax given the patient supine. Mobile phone with keys on the side here is the only apparatus we can see. And there's a few rib fractures there too. For case 3 is another trauma patient who's been hit by a motorcycle. Let me just make sure. Well, again, this X-ray seems to show an issue over here. Whether or not this is collapse, consolidation, or something else. You get the feeling maybe there might be a scapular fracture through here, but certainly you've got rib fractures here and a possible hemothorax on this side. If the patient's lying supine, it can be easy to see that the blood can go and spread throughout the lung. So the suggestion here is the patient's got rib fractures with pulmonary contusion or hemothorax. Here's case 4. A 20-year-old man with recreational drug use coming to the ED with chest pain. He's a bit hypertensive for a young man. Here's an example of mediastinum. So there's some emphysema, some subcutaneous emphysema there. This could be due to a bunch of issues, but essentially you can have big changes in the airway pressures due to inhalational maneuvers. There's a 52-year-old lady who comes in to her ED with breathlessness after some treatment for cancer. Have a look at the X-ray and let us know what you think. So you can describe the X-ray and outline the differential diagnosis. So this X-ray appears to show a large pleural effusion, multiple parenchymal lesions. This is typical of metastatic lung disease, as well as a corticaf. He also might have had a mastectomy and has an oxygen. So we're just going to go back and show you that. There seems to be these distinct lesions over here, which could be lung nodules or maybe metastases. She has a mastectomy here. There's a corticaf, and there's this large effusion here, which we have to assume is malignant integral otherwise. Not the trachea is in the midline, the patient isn't intubated, there's no central line apart from this cortical. So pleural effusions can be divided into transudates and exudates, and you can use Likes criteria for that. So these are some of the causes of transudates and exudates. Obviously you have to take a fluid sample to determine the protein content. So this is a 60-year-old man from a nursing home who's choked on his dentures. Describe the X-ray and what may you do after you've done the X-ray. So we're trying to work in through that doctor's ABCD approach. So demographics, we know it's an old man from a nursing home, doesn't look particularly rotated, it's good penetration. The apparatus, well, there's no central line, he's not intubated. Does appear to be a possible foreign body here. The trachea is in the midline, and the corona is here. The hilum look normal. Mediastinum isn't dilated. The lung fields are relatively clear. Heart borders are maintained, as are the diaphragmatic borders. And then there's no evidence of any soft tissue injury or anything else. It's obvious, so it looks like there's a problem in the esophagus perhaps. So it says here the chest X-ray shows the dentures overlying the mediastinum. It says there may be some air in the soft tissues as well as possible esophageal perforation. When we go back to see if we can see that, the question is there any air up here? There's 3 more cases to go. An 18-year-old with asthma presents with weight loss and cough and malaise, and she's had some antibiotics. Have a look at the X-ray and list some differential diagnoses. Okay, so you've walked through this X-ray. Looks like some patchy pacification, some fluid in the pleural space. It's quite a broad differential diagnosis given how long she's been sick for, but there's something going on here as well as here. There's definitely some asymmetry between the 2 lines, but there is no pneumothorax, and the patient didn't have any apparatus in the trachea or any central line, but certainly there's something going on in that right line. A 35-year-old homeless guy comes in with an increasing cough. Here's his X-ray. Describe what it looks like and what possible causes might be. This is chest X-ray. Looks like it shows a large cavitating lesion. Some of the causes will include infective, cancer, as well as things like vasculitis and pulmonary embolism. So a 4-year-old boy comes into ED after he's choked in the house 30 minutes ago. We describe and interpret his X-ray and what to do as your further management plan. So this is a chest X-ray showing a large foreign body. Maybe it's a corn, maybe it's a button battery. You've got to be really careful as to where this will be, but the classic teaching is on an AP or PA, the crowns in the esophagus are oriented to the mucosa column, whereas crowns in the trachea are oriented to the sagittally. So obviously this is quite far down, but you can use this to your advantage when the crown is up here. So if this is a button battery rather than a coin, it could cause a lot of damage. Batteries can get lodged and they can cause significant release of alkaline contents. And this is a real problem, so it needs to be removed with endoscopy. So you should get the colleagues from gastroenterology to remove these within about 6 hours. And occasionally they'll pass themselves, but generally they need to be removed fairly urgently. So, last case, called to the ward, check the nasogastric tube. Where should the nasogastric tube be and where is it in this case? Okay, so normally we expect it to be just left of the midline coming down here and into the stomach, 10 centimeters below the diaphragm, but in this case it seems to have gone to the carina, it's taken a U-turn, it's crawled in that main bronchus. So this is not a tube that we can use for feeding. We need to remove it and put a new one in. So, thanks a lot.